I'm going to show you the four most overlooked structures involved in anterior knee pain and how to assess and treat them yourself at home. Remember to read those research bombs I'm dropping throughout the video and drop any in the comments that you have to contribute to that sweet, sweet data. Stick around because we'll be giving away something that helps increase your proprioception at the end of this video. I often have clients come in with persistent and stubborn knee pain that just won't resolve. This lets me know that there's something more complex going on. And often, after doing a full body functional assessment, I will gravitate towards these four structures in the knee as part of my global treatment and corrective exercise. Stick around because structure number 2 has fixed a lot of knees, acting as both the cause and the symptom of the pain in many clients with previous injuries. Comment below if you can guess what it is. Hint: 1, it's not a tendon, ligament, or a muscle. And 2, it's a richly innervated structure. Let me know in the comments below if you can guess what it is. I need to start this by saying that if you have knee pain, then you have a larger biomechanical dysfunction. And that dysfunction is causing abnormal forces to go through the knee, causing you pain. So you absolutely, without a doubt, must look globally to fix the problem for good. And when I say globally, I don't mean just doing squats and power stretching your quads to fix your anterior knee pain. What I mean is look at global dysfunction, things like pelvic positioning, which can change the activation ratio of your quadriceps, thoracic curvature, which directly impacts pelvic positioning on both sides, and foot mechanics, which can drastically alter the function of the knee, the magnitude of the forces going through the knee, and where those forces are located. And this is just to name a few. I've seen plenty of clients where fixing things such as jaw positioning has directly improved the function and the forces going through the knee, restoring proper biomechanics to the entire system, which is the ground up and, more importantly, the spine out, is the long-term solution to fixing your pain, your problems, and improving your performance for good. With that out of the way, let's look at the 4 most overlooked local structures that could be causing and are most definitely involved in your knee pain. Let's start with structure number 4. Some researchers call it the 5th quadricep. This little muscle gets immediately forgotten by most anatomy students, if they're even taught it. It can be a primary source of dysfunction in people with osteoarthritis and limited range of motion of the knee. This muscle is called the Articularis Genu. The Articularis Genu exists on the front of the distal femur, deep to the vastus intermedius, and separated by a clear fascial plane with a discrete neurovascular supply. If you were to pinpoint it on the body, it would exist about here, sitting behind the quadriceps tendon here, about 12 to 16 centimeters in length, depending on the individual. Its primary job is to act as a functional unit with the vastus medialis and the vastus intermedius to tense the joint capsule when entering full extension. An often overlooked function by clinicians, and in my opinion, the most important function of the Articularis Genu, is to laterally tension the vastus intermedius during knee extension. This additional overlooked function could have significant clinical implications in patellar tracking, vastus medialis and vastus intermedius activation patterns, and quadricep activation patterns as a whole. So all of that time therapists spend trying to get your vastus medialis to fire could be altered if the Articularis Genu is addressed. The Articularis Genu can cause many problems in the knee. Here are some of the problems I see often. Number 1, when a patient is entering full extension, they feel pain or discomfort. Number 2, the vastus medialis or vastus intermedius are dysfunctional and either under or over firing in relation to the vastus lateralis. 3, we see a patella that tracks too medially during extension. Number 4 is having limited or decreased extension over a long period of time. We also know that the Articularis Genu can degrade when knee range of motion is limited. This can lead to all 4 of the above conditions and can be present in people who have had previous injuries, surgeries, as well as osteoarthritic conditions in the knee. If you have any of these symptoms, the Articularis Genu is part of the problem. But keep watching, because everything from the Articularis Genu to the number 1 structure we look at is going to be a part of your knee dysfunction. So without assessing all of these structures, you can never fully fix knee dysfunction and pain. Now to find it, we're going to start with a straight leg. Measure 2 to 3 fingers above the patella. Now, palpate the front of your knee. You'll find a thickened area. Move laterally to this. This thickening is the quadriceps tendon. Now, when you're on the side of the quadriceps tendon, push medially and deep, trying to contact the anterior portion or the front of the distal femur. This deep pressure allows us to feel the fibers of the Articularis Genu. Move your thumb around on the Articularis Genu to feel the quality and the direction of these fibers. Tenderness in this spot is normal, but can indicate that the Articularis Genu is in fact a problem. Now for the mobilization. This is what you've been waiting for. Our active mobilization is going to stress the entire quadriceps unit as well as the fascia connecting to the Articularis Genu in order for it to free up the muscle and break up any adhesions that may be impacting the quality or the motion of the Articularis Genu. Even though we palpated this by moving the quadriceps tendon medially, we can get to the fascia of the Articularis Genu and improve its function by working on the fascial matrix direction that has the most restriction. Because the fascia is one big spider web, you can even work on the Articularis Genu indirectly through the surface of the skin using light pressure with something like the fat tool, which you can use at home, and I'll show you in a later video how to treat the front of the knee using fascial abrasion technique. When palpating the front of the knee, you'll notice that the medial or lateral direction resists more than the other. This is the side you're going to use, and this is the direction of force you're going to apply in order to mobilize the AG. With this, when I see dysfunction in the Articularis Genu, I often notice the most tension when pushing laterally. This means that the fascia is resisting the natural motion of the Articularis Genu and could be causing dysfunction directly or indirectly by resisting its motion. You can see in my knee that this in fact is the case, and when I push laterally from the medial side of the quadriceps tendon, I generate the most resistance on the tissue. Next, we're going to add the compound movement to get more bang for your buck in the whole body fascial matrix. We're going to do this by checking rotation of the hip. With a straight leg, rotate your hip internally and externally. You're going to ensure that your thumb stays on the same place relative to the knee. Rather than you pushing your quadricep into your thumb, you're following the knee as you rotate the hip. This is going to give you the best picture of resistance. Remember, whichever direction causes more resistance against your thumb on top of the initial resistance. In my case, when I internally rotate my hip, I feel much more resistance than when I externally rotate the hip. So as you can see, internally rotating my hip also increases tension at the site. Now for the actual mobilization. You're going to use this tension spot you found before. With a relaxed quad, you're going to push deep and down like we did in the palpation, as well as into the direction of tension. You want your thumb to be pointing where the tension is developing the most. Remember, on the medial side, you're working through more quad in order to get directly to the Articularis Genu. So assessing both sides may be beneficial after the initial pass. Now, with a relaxed leg, you're going to slide the heel along the floor while applying this tension in order to flex the knee. As the knee flexes, you're going to feel increased resistance against your thumb. Remember to maintain contact pressure and slightly increase the pressure you're using with your thumb as this resistance is felt. Do this nice and slowly so the fascia can fully relax. We're going to repeat 3 times, and then we're going to add the compound movement. Now to add the compound movement. My internal rotation increased the tension against my thumb, so I'm going to double check this. And I'm going to slightly internally rotate my hip. In this position, I'm going to do the same motion as before and slowly increase the amount of internal rotation with each pass. When doing this as a clinician, you're going to compound the movements all together and develop tension. But doing this at home, it's easiest to add one piece of tension at a time. Let's repeat 3 to 6 more times. And now we're going to reassess the tension from a straight leg. Notice how my tension has significantly decreased when pushing in the lateral direction. Now, traveling distally from Articularis Genu, but still interconnected to the AG, we're going to look at structure number 3. This structure contributes to patellar instability more than just the quads alone and may be a key player in anterior knee pain. The patellar retinaculum is a fibrous structure that helps stabilize the patella during extension. The retinaculum has two parts, both of which are important and both of which can be treated: the medial and lateral retinaculum. The medial retinaculum attaches to the patella, the tibial condyle, the vastus medialis, and the quadriceps tendon on the medial side, or the portion of the quadriceps tendon called the ligamentum patellae. The nerve to the vastus medialis, saphenous nerve, as well as branches from the obturator and sciatic nerve, all provide substantial innervation to the medial retinaculum. This could be clinically significant for a lot of different reasons, and indicates that the medial retinaculum could be a key player in vastus medialis function. The medial retinaculum contributes to patellar stability up to 30 degrees of flexion in some studies. The lateral retinaculum on the lateral side of the patella gets much less hype due to its tendency to avoid patellar dislocation damage. That doesn't mean it's any less important than the medial retinaculum, and some studies may even show that it may be more important when involving patellar stability. The lateral retinaculum attaches to the patella and blends with the quadriceps tendon on the lateral side, as well as the deeper portion of the vastus lateralis, specifically the deep transverse fibers of the vastus lateralis obliquus. The lesser loved retinaculum also is shown to contribute to stability of the patella throughout the entire range of flexion, unlike the medial retinaculum, which only contributes up to 30 degrees of flexion. Notice the theme here, where the patellar retinaculum is touching and integrating with the same structures as the Articularis Genu. There's a few pieces of evidence that provide anatomical indications whether or not the patellar retinaculum is a problem. If a patient's anterior knee pain is patellofemoral, then we can see thickening in the patellar retinaculum in a lot of cases. The retinacula can also be dysfunctional if there's an instability with the patella. If you often have patellar tracking issues, instability, or dislocations, the retinaculum most definitely is a key component in fixing your problem. Imbalance of the retinacula can lead to patellar instability and also cause greater forces to go through the knee, which can lead to abnormal loading, which leads to pain, inflammation, and overall systemic dysfunction. Patellar stability is often attributed to the quadriceps, with many exercises focusing on vastus medialis activation. But studies show that the patellar retinaculum plays the greatest role in patellar tracking and stability when compounded with weak quadriceps. And weak quadriceps alone do not create more forces or instability through the patella. Finding the retinaculum is easy. All you have to do is look on the lateral side of each knee. You can see it here and here. Mobilizing the retinaculum at home is easy, though it requires a little bit of force. Warning: if you have lateral patellar dislocation, do not do this mobilization, especially to the lateral side. That being said, medial mobilization is safe for most people, and studies show it could be beneficial and a key player to mobilize and restore the lateral retinaculum in patellar dislocation cases. Start with a straight leg. Pull your kneecap medially and laterally. It should be nice and loose. You'll notice one direction, it moves quite significantly. You can see that here. And the other direction, in my case, laterally, it's more restricted and has more tension on it. Notice how my patellar retinaculum is tighter in the direction that my Articularis Genu and quadriceps unit also had a lot of tension in. Again, fix globally, assess each structure. To mobilize the retinaculum, we're going to put both thumbs on the side that's less mobile. We're going to take our fingers and wrap them around, contacting the bone under the patella on the opposite side to stabilize. Now we're going to push the patella and pull with our fingers, holding in the stuck direction. The motion looks like this when your fingers aren't on the patella. Your thumbs will stabilize on the patella, and your fingers will reach around and press the bone. This is what the position looks like. You're going to press with the thumbs and pull with the fingers. This is the motion you're making. Hold this for 30 to 45 seconds to allow the fascia to relax, and repeat 2 to 3 times. As always, reassess the patellar mobility after. You can also palpate through the retinaculum to see if there's thickened bands on the side that's more restricted, but we can get into that more in our clinical video. Moving from the retinaculum, structure number 2 contacts it as well as blends in with the joint capsule, which Articularis Genu, surprise, tenses as one of its motions during extension. So let's go from here and look at Structure number 2. Let me know in the comments below if you got it right before the big reveal. But structure number 2 is the infrapatellar fat pad. Or in our case, we're just going to call it the fat pad. The infrapatellar fat pad, or the fat pad, is a small deposition of fat which exists behind the synovial membrane of the knee, sitting behind the patellar tendon. The fat pad is composed of adipocytes and receives an abundant supply of blood vessels and nerves. This can be the pain generator in a lot of cases. The infrapatellar fat pad often develops adhesions, which sticks the fat pad in essence to the back of the patellar tendon. This can cause disruptions in blood flow and a lot of pain. It's also shown that immune cells can infiltrate the infrapatellar fat pad, which can be a major source of inflammation in the anterior knee. The infrapatellar fat pad can also contain metabolites that contribute to conditions like osteoarthritis, which a couple structures above wastes with osteoarthritis. The fat pad may also play a crucial role in healing and protection of tissues that are surrounding it. And in the inverse of this, degeneration. Some research suggests that the fat pad may assist in external rotation of the tibia relative to the femur, assists in maintaining lateral tracking of the patella, and even maintaining proper patellar contact pressure throughout ranges of motion. Knowing if the fat pad is a cause of your knee pain rather than a symptom, there's a few key factors that I see often with clients when this is the primary source of pain, not just the pain generator. Number 1 is the description that a client's knee feels like it's about to explode or has shattered glass in it when doing a motion that's actively loading the patellar tendon, such as a single leg squat or a double leg squat. This is often alleviated when doing a more hip hinge squat, such as a back squat, and elevated when doing a more quad dominant squat, such as a front squat. Visually, if the fat pad is a problem, you'll often see puffiness on either side of the tendon. Now, to mobilize the fat pad at home. There are 2 ways we can mobilize the fat pad, and both of them go through structure number 3, the retinaculum, to mobilize the fat pad. First thing we're going to do is assess the direction of tension. If you see a side that's puffy, that's often going to be the side that's problematic. First, with a slightly bent knee, providing slight tension to the patellar tendon, you're going to fall back behind the patellar tendon and your thumb's going to fall into a valley. You're going to push medially and laterally on that valley on either side of the knee. You'll notice one side moves better than the other. You can repeat this in a straight leg position to assess the deeper ranges of motion. Now to mobilize. There are 2 ways we're going to mobilize this. Number 1, we're going to do a technique called S-bowing of the patellar tendon, but we're going to allow one thumb to fall behind the tendon on the problematic side. First, you're going to take one thumb and put it on the non-problematic side, so the side that doesn't have more tension, and you're going to put it on the patellar tendon away from the patella. And you're going to put your thumb close to the tibial tuberosity where you can still grip the patellar tendon and there's still motion. The other thumb is going to go on the opposite side behind the patellar tendon, slightly above the tuberosity. In that space. Now you're going to push your thumbs in opposite directions.
So I'm just creating an S with that.
In this direction, we're going to hold for 30 to 45 seconds, and you should feel some tissue relax. Repeat this 3 or 4 times and reassess. The second option is a little bit more aggressive and a lot more like our first mobilization. You're going to start with the knee in a slightly flexed position. You're going to push your thumb into the side of the fat pad behind the patellar tendon that developed the most tension in step 1. What you're going to do now, pressing your thumb into the fat pad and towards the patella slightly, you're going to slowly flex your leg. Try your best to keep your pressure behind the patellar tendon and only enter enough flexion where you're not getting a lot of tension on the quadriceps. Again, we can repeat this 3 to 4 times and add the same compound movement as the Articularis Genu. Once this is done, reassess by pushing into that area of the fat pad on each side once again. You should notice more movement in the fat pad on the side that was restricted. Finally, we're going to go into the most important muscle when talking about knee injuries and knee dysfunction. It's not the quadriceps, it's not the hamstrings, and it's not the calf. This muscle is problematic in every knee case I see, regardless of whether it's causal or reacting as a result to that person's dysfunction. And that muscle is the popliteus. The popliteus is the gatekeeper to resolving almost all knee problems. If you ignore the popliteus, you will not get complete restoration of knee mechanics. The job of the popliteus seems small, but it's pivotal to knee function. Its job is to internally rotate the tibia in relation to the femur to stabilize the knee between 0 to 30 degrees of flexion, and some resources show that can exist through almost the entire range of motion depending on the loading patterns of the leg and the weight-bearing status of the individual. The popliteal function also increases and covers a larger range of motion when a patient is weight-bearing. This means it plays a crucial role in any movement where you're contacting the ground. The popliteus muscle extends over the posterior aspect, that means the back of the knee joint. It's the deepest muscle sitting right against the joint capsule. The popliteus starts at the medial edge of the tibia right here. Laterally, the popliteal tendon penetrates through the joint capsule, connecting to the lateral meniscus, the posterior meniscofemoral ligament, and the articular capsule, as well as the femur. The job of this small triangular muscle is pivotal in the function of the knee. It internally rotates the tibia in relation to the femur. That means it points your toes inwards when your thighs are staying still, unlocking the knee, as well as stabilizing the knee through 0 to 30 degrees of flexion. Some research even shows that the popliteus is active in both flexion and extension, much further than this 30-degree range of motion cutoff. The popliteus also increases activation with weight bearing, which suggests it plays a crucial role in stabilization of the knee as the forces become greater. The popliteus can also have constant activation through the eccentric phase of knee extension, as well as the concentric phase. But the concentric phase is variable, distinct, and dynamic compared to the eccentric phase. Overall, the popliteus may provide 3 dimensions of stability within the knee joint as soon as it's active. Knowing your popliteus is a problem is pretty simple. If your knee does not fully extend, this is the biggest indicator that the popliteus is an issue. Even though it's on the back of the knee, it also contributes to anterior knee pain and can significantly alleviate anterior knee pain when treated. This contribution partially comes from its inability to allow the knee to fully lock when problematic. This causes abnormal and excess force through the anterior knee and patellar tendon and never allows the quads to relax as if the knee were fully locked out. You can try this at home by slightly bending your knee and standing on one leg, and then fully extending your knee and standing on leg. And then you can squeeze your quads and notice the difference in activation in each position. On top of this, as I mentioned before, the popliteus is almost always an issue in previous knee injuries, surgeries, or recurring anterior knee pain. So let's get into the mobilization. To palpate the popliteus, first, we come to the medial part of the tibia, just in front of the tibial tuberosity. You'll notice a hard bony edge. You're going to fall behind that hard bony edge near the calf. Pushing laterally and slightly forward, you should feel a difference in tissue against the tibia. This is the popliteus. To find the lateral insertion of the popliteus, you're going to bend the leg at 90 degrees. When bent, the tendon of the popliteus actually falls in front of your IT band. This is clinically significant for IT band friction syndrome treatment, as the pain generator may actually be the popliteal tendon rather than the IT band or the bursa itself. Now, we push forward towards the patella on the back of the bony prominence of the femur. You should feel this little grain of rice immediately in front of the IT band. That's the lateral attachment of the popliteus. Now for the mobilization. There are 2 ways to mobilize the popliteus. Because there's a lot of nerves and veins that go through the back of the knee, you don't want to put much pressure on there at home. So you can use a non-aggressive fascial mobilization tool, or you can use this mobilization on the medial portion of the popliteus. First, you're going to put your fingers back on the medial portion of the popliteus. In this position, it's easiest to use the opposite hand to the side you're treating, as well as the thumb of that opposite hand rather than your fingers, but you can use what's most comfortable. Starting with a flex knee position, you're going to point your toes medially and laterally, or internally and externally rotate the tibia in relation to the femur. As we did with the hip and the Articularis Genu, whatever motion increases tension against your thumb is the motion you're going to use as the compound motion. Next, we're going to add a third compound motion of this, which is the ankle. To do this, you can plantar flex or dorsiflex the foot. Again, whichever motion increases the tension is the motion you're going to use. Now, with the flex knee and your thumb in position on the popliteus, you're going to slowly extend the knee. The thumb should be pointing medially and slightly inferior. For those of you at home who know what you're doing with matrix release, chase the tension. As you start to extend the knee, you're then going to provide the internal or external rotation of the tibia, and at the same time, you're going to provide the plantar or dorsiflexion of your foot. As you can see with my knee, the internal rotation of the tibia and the dorsiflexion of my toes increases the tension on the popliteus the most. We're going to repeat this move slowly 3 to 6 times, work all along the borders of the popliteus, and now check your knee extension once again. If you didn't have limited knee extension, you won't notice a difference here, but in many cases, including my own, I have limited knee extension, so I did notice a difference. And there you have it. The 4 most overlooked, but 4 incredibly clinically significant structures involved in anterior knee pain and knee pain in general. If you'd like me to go into a deeper dive on any of these structures, as well as provide more clinical treatments, or if you'd like to see more at-home treatments, let me know in the comments below. In most cases, a combination of one to all of these treatments will provide significant improvements in biomechanics of the knee if that area was problematic. And therefore, we will see changes in pain and changes in global function in a positive direction. There have also been a lot of clinically significant research bombs dropped through this entire video. So remember to check out that link tree and let me know in the comments below if you have more data to back up any of these or refute any of these findings. I'm always happy to go back on something I know and do what's best for the patient. Now we're going to give away a couple boxes of performance tape. If you like, subscribe and comment below a research bomb you'd love me to dive into or a topic you'd love me to cover. I'll send this to a winner in the next video and keep following up until my box of 50 is completely gone. This is one of the best KT tapes on the market. It has the best adhesion to muscles and doesn't come off without you peeling it off. Kinesio tape is shown to help proprioception, and we'll get into that in subsequent videos. Comment below the color you'd like along with your research bomb or topic, and watch out for the next video where I announce the winner. As always, thank you so much for watching. Please let me know if you have any questions, comments, or if there's any data or information you'd like to see me improve in the next video. That's all for me, and I hope you get your knee pain resolved.